Okay, can you hear me? Hear my
Yeah.
voice?
Okay.
Okay, okay,
Okay. Yeah.
okay, okay.
Yeah.
Yes, yes.
But I can't hear your voice. But
Why?
Oh,
shall I start? Anyway,
Okay.
I will
Okay.
start.
Start. Yeah.
Oh, okay. If I have any trouble, please send me some message or
Sure.
some gesture. So like
Yes.
this.
Yes.
Okay?
Okay.
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 yes.
I will start. So today's my talk is complication of the UKA. Yesterday, I talked about the usage of the UKA and comprehensive complication survival rate. Today, the detail I will talk about the detail of complication. Oh, this is the result of this is the Sweden doctor. So this is the UK. This is my hospital. The survival rate complication is very quite different. In the European countries, infection and lateral OA is more frequent. But in Japan, or maybe in some other Asian countries, fracture is more frequent, maybe due to the osteoporotic bone and very small size bone. So anyway, so we always use the mobile bearing Oxford UKA. So it can dislocate due to the no constraints. So the bearing can move passively, completely passively, according to the movement of the tibia and the femur component. So, but in contrast, there is very, very rare where rate is very, very small. But if there is some impingement between a bone or osteophyte or other thing, sometimes bearing wear is very obvious. So during the operation, we need to check about the impingement, both extra-articular and intra-articular impingement. So extra-articular impingement, that means come from the bone fragment, and intra-articular impingement to the hit to for example, so cement or some bone edge of the intercondylar notch. But most serious problem is dislocation. Sometimes the patient suddenly feel the pain. And on the X-ray, we can see the bearing here because this bearing has the marker, tantalium marker, and the dot and the bar. So we can easily recognize the dislocation. So there are some cause of the dislocation. So one cause is imbalance. That means the gap balance between the flexion and the extension. So primarily means this is the operation error, technical error. So at the time of surgery, so balance is already the bad. For example, loose flexion gap or loose extension gap. The secondary means it is sometimes occur after the very tight gap. So that means the insert the thicker bearing. So it can cause the abnormal elongation of MCL and subsequent elongation and medial side loosening. And that can cause the secondary loose of gap. So second cause is impingement. It can cause by posterior cam. That means some osteophyte here or some remnant meniscus here. During deep flexion, the osteophyte or remnant meniscus can push the bearing anteriorly that can cause the anterior dislocation of this bearing. And on the lateral wall. So I will explain later the detail of this mechanism. And the spinning. The bearing spinning can also cause the dislocation because the bearing is thicker in the anteriorly and a little bit thicker the posteriorly. In the anterior side, the thickness is 5 millimeter thicker compared to the thinnest side of the bearing, and posteriorly, the 3 millimeter higher. But both sides is only 1.5 millimeter. So if the bearing rotates 90 degrees, the bearing can dislocate easily. So to avoid dislocation, it is really important to adjust the gap between the flexion and extension. But sometimes, so in the Oxford manual, so the extent gap should be evaluated in the 20 degrees in flexion, because in the full extension, the posterior capsule will be tight, and that shorten the extension gap due to the posterior capsule. Sometimes posterior capsule is contracted due to the flexion contracture. But in fact, sometimes some patients have the looser extension gap compared to the 20 degrees. So we routinely evaluate the extension gap at 20 degrees and 10 degrees, both. Oh, this is a cam impingement. So it is quite important to remove the osteophyte here. Otherwise, in the flexion, this osteophyte will push the bearing anteriorly, or some remnant meniscus. Because in the procedure, the meniscectomy, especially for the posterior horn of the meniscus, is really, really difficult because of very limited space to achieve the meniscectomy. And also the osteophyte like this, and two small components can cause the overhang of bone here, so that also cause the dislocation. And this is the thicker bearings. So for the beginner surgeon, worry about the dislocation. So it tend to insert the tighter, thicker bearing to avoid the dislocation. But in fact, this can also cause the dislocation because if we insert the thicker bearing, it can cause the over tightness of medial side, and this side, lateral side, can cause the overload. Then the medial side, so this over stiffness can cause abnormal elongation of MCL. Subsequently, medial side can lose, and then the bearing can dislocate easily. And in addition, the lateral side, the OA change can occur due to the overloading of the lateral side. So we should avoid the over stiffness. In other words, overcorrection should be avoided. And the cause of dislocation is wall hitting. So previously we are focused on the anterior and posterior movement of bearing, but in the coronal movement, the medial lateral movement is also important because like this, two medial placement of bearing can hit the bearing, the hit against the lateral wall of tibia tray. That can cause the lateral dislocation of bearing. And to avoid this one, to place the femur component properly, it is very important. So in other words, so relationship between the tibia tray and the femur component is very important because the bearing will move completely passively according to the movement of the femur component because this is the perfect configuration, articulation between the femur bone and the bearing, just like the THA. So if the femur component placed too laterally, the bearing will move laterally and hit the lateral wall and can cause a dislocation. So again, during the surgery, it is really important to place the femur component at the center of the femoral condyle, femoral medial condyle. It is very important. In contrast to lateral medial placement is also dangerous because, as I said before, the anterior height is 5 millimeter higher and the posterior side is 3 millimeter higher. Oh, this is a wrong number. Only the 1.5 millimeter higher in the both sides. So this separation between the lateral wall and the bearing can cause the spinning like this. In this situation, the jumping height, that means the different height difference between the thinnest and highest is only the 1.5 millimeter. This is a wrong number. 1.5 is correct. So in this situation, it is quite easy to dislocate, just like the very shallow THA, like this. So how to treat the dislocation? Sometimes we can reduce to the close reduction is successful. So I experienced 2 or 3 patients. So I could to deduct the dislocated bearing manually, with the closely. So only the friction, deflection, and then extension. After that, surprisingly, sometimes this bearing is deducted. But in most cases, we need to open reduction, so remove the bearing. Sometimes it is very difficult because it moves too posterior or too anterior. So sometimes we need to the dislocated bearing using the fluoroscope. And we need to identify the cause of dislocation. So check the impingement in the both anteriorly and posteriorly. Is there any osteophyte or is there any remnant meniscus or some bone edge? And in addition, we need to check the distance between the bearing and lateral wall of the tibia tray. Sometimes it's too tight, the bearing hit to the lateral wall, and in other cases, it's too separated from lateral wall to the bearings. And then change the bearing. We do not use the same bearing, same bearing again, because this bearing is already damaged. So we need to prepare the new bearing and insert. And sometimes the same thickness bearing is enough, but some cases we need to insert the 1 millimeter or 2 millimeter thicker bearing. But again, we need to avoid the overstiff, overcorrection. Otherwise, the media sides abnormal elongation of the MCL and lateral side, the OA can occur in the future. But sometimes it is quite difficult to adjust the balance to, even to using the 1 millimeter or 2 millimeter thicker bearing, so the bearing can dislocate easily. In this case, we need to revise to the fixed bearing like this. I experienced only one case, is frequent dislocation case. So it is quite difficult to impact to place the female component at the ideal position because to achieve the ideal placement of the bearing, in other words, the ideal placement of the female component, it is quite important to relationship between the tibia tray. It is perfect if there is a 1 millimeter or 2 millimeter space between lateral wall of the tibia tray and bearings. And it needs to keep throughout the motion, from the full extension to the full flexion, and keeping the same distance between lateral wall and bearing. It is quite difficult to achieve this, the position of sagittal cut and placement of the female component along with the direction of sagittal cut, because this bearing move anteriorly and posteriorly according to the knee motion. So to achieve the ideal placement, the site of sagittal cut and direction of sagittal cut is very important, but nobody knows the true answer. So this is my object of my study, to what is the best direction for the tibia sagittal cut. And this is a fracture. Fracture is also the really serious problem for the, especially for the Asian patient, because in the Asian country, fracture is very frequent, especially for the Japanese one. In contrast, in the European countries, so fracture is really rare, because the bone morphology, bone density is quite different, and bone size as well. The European country, the patient has a very big bone and straight bone and very strong bone. But on the contrast, in the Asian patient, especially for the elderly female patients, the patient that has the very osteoporotic bone, easy to break, and on the small size. And in addition, the many Japanese, the Asian patient have the tibial vertebra. Tibial vertebra can cause the fragile bone. So in the literature, the cause of fracture is a technical error. So, for example, the force hammering, hard hit hammering to insert the tibia tray, improper pinhole. Sometimes the hole here can cause the fracture and the breakage of the posterior cortex during the sagittal bone cut or keel slot making. Then once the mechanical examination showed that the too deep sagittal cut can cause the working bone strength and can cause the frequent fracture after operation. So we need to avoid the deep sagittal cut. And similarly, the too deep keel throat should be avoided. So too low cut and too medial cut can also can cause the fracture. But even in the experienced surgeon, the fracture can cause not so rare. So that means the fracture, the cause is not only the operator side, but also the patient side. So as I said before, so many Japanese patient has the tibia bara. So I made this line. This line is means the parallel to the tibia axis and its pass at the tip of medial condyle, medial tibial spine. We call the ME line, medial eminence line. So if the line pass intramedullary within the bone, the patient does not have tibial bara. But in contrast, this patient has this ME line pass outside of bone. That means the patient has the tibia bara. So morphological difference is obvious. This patient has very overhang the medial tibia condyle. So if we implant the UKA like this, and the fracture is more frequent. So we examined the two types, this type and this type, and compare the fracture rate is 14 times higher in the risk of fracture. So in this patient, we should take care. This is the cementless tibia. So cementless is very easy to break. It can cause very frequently the fracture. So this is the patient with the cementless tibia. So in this patient, we carefully use the cemented implant. So, but in basically for the beginner patient, beginner surgeon, these patients should be avoided to the initial phase of the operation. Now, the treatment is